In our third video, we are going to cover how to diagnose community-acquired pneumonia. Let's review our patient's illness script. A 66-year-old man presents with subacute onset of shortness of breath, dyspnea, at rest, accompanied by fever, myalgias, headache, and a non-productive cough. He denies chest pain. He has marked tachypnea, respiratory rate 30, sinus tachycardia, low oxygen saturation, and rouse at both posterior lung fields. Epidemiology is remarkable. We developed this in the late fall. He has no known sick contacts, no animal or environmental exposures, and he did not receive the flu or the pneumococcal vaccines. Past medical history is a 40-pack-year smoker and may have COPD. Let's first briefly review his physical findings and what changes you should look for when examining a patient with community-acquired pneumonia. We generally focus on the lung exam. Time does not permit a full description of the pulmonary exam. However, key findings to look for are RALs, indicating fluid in the alveoli, and evidence of consolidation, E to A changes or egophony, and bronchovesicular breath sounds. The lung should also be percussed, dullness found in areas of consolidation or where pleural fluid has accumulated. As you review your findings from history and exam, you should first ask the question, how ill is my patient, and is this an emergency? Next, depending on the severity of illness, what test should I order? And finally, what do I think is the most likely diagnosis? To help clinicians assess the severity of CAP, a simple but reasonably accurate scoring system, CURB-65, can be used. This mnemonic prompts the clinician to ask, is my patient confused? Is their BUN level over 19 indicative of dehydration? Is there a respiratory rate of 30 per minute or higher? Is the systolic blood pressure below 90? And is my patient age 65 or older? For each yes, the patient receives 1 point. 0 to 1 points indicates mild disease, and these patients can go home. 2 represents moderate risk, and the patient should be hospitalized at a medical surgical ward. And 3 or higher is high risk, warning MICU placement. Our patient is 65 and had a respiratory rate of 30, scoring 2 points, indicating he required hospitalization in a medical surgical ward. Next, after assessing illness severity, when you are considering pneumonia, what key tests should you always be ordered? For all patients in which pneumonia is being considered, a chest X-ray should be one of your first tests. There are 3 major radiologic patterns in cases of CAP: lobar, bronchopneumonia, and interstitial. I tried to illustrate them in these sketch notes to emphasize key characteristics schematically. However, actual chest X-rays are required to fully appreciate the differences between these 3 patterns. 1. Lobar. The bacteria do not cross the lobe fissures. The pathogen most likely to cause this pattern of infiltration is Strep pneumoniae. Less commonly, Legionella, Mycoplasma, and Chlamydia pneumoniae can cause lobar infiltrates. Rarely, Haemophilus influenza and Staph aureus can result in this radiologic pattern. 2. Bronchopneumonia. Infiltrates are near the bronchi and are multifocal. Pathogens associated with this pattern include Staph aureus, Haemophilus influenza, Klebsiella and Pseudomonas, and rarely Strep pneumoniae. Viruses can also cause this pattern, particularly influenza, RSV, and rhinovirus. Interstitial pattern consists of fine, multifocal linear thickening of the lung interstitium and is most commonly seen in association with Mycoplasma, Chlamydia, Legionella, influenza, RSV, SARS-CoV-2, Pneumocystis jirovecii, and CMV. As seen on this X-ray, lobar is a dense homogeneous infiltrate outlining 1 or more lobes. Bronchopneumonia pattern consists of multifocal opacifications often centered around the bronchi. Infiltrates are distributed in multiple lobes and often form ill-defined nodules. Interstitial pattern usually consists of diffuse bilateral opacities with a net-like pattern involving the interstitium of the lung rather than the alveoli, and may be associated with ground glass opacifications. Another helpful test that is performed in all patients requiring hospitalization is a sputum gram stain. It is important that the sample come from deep cough. The sample should contain less than 10 epithelial cells from the buccal mucosa to assure only modest contamination by saliva, and should have more than 25 ppmn per low power field. In most cases, with the exception of aspiration pneumonia, there should be a predominantly one organism. Here is a classic example of a sputum gram stain for strep pneumoniae. Note the degraded gram-negative or pinkish-colored PMNs and the gram-positive diplococci. The sputum gram stain is also very helpful for assessing the inflammatory response of the lung. In bacterial pneumonia, you will see large numbers of PMNs and a predominance of one type of bacteria. In viral pneumonia, Mycoplasma, Chlamydia, and Legionella, you often see monocytes or a few PMNs and no bacteria. Sputum culture can be helpful in bacterial pneumonias, but should only be obtained in combination with a gram stain to assure the sample reflects lung contents and not saliva. Positive cultures can subsequently provide antibiotic sensitivities. Finally, respiratory PCR is now available to identify nearly all viral and a limited number of bacterial pathogens. More inclusive panels are rapidly evolving. This test should be ordered in patients who are being considered for hospitalization. For those going home, little additional testing is required. A peripheral white count with differential, a procalcitonin, and a CRP are helpful tools for differentiating bacterial from viral pneumonia. In bacterial pneumonia, the white count is usually elevated with an increased percentage of PMNs, and younger forms, band forms, may be seen. While in viral pneumonia, the white cell count is usually normal with a normal percentage of PMNs. Procalcitonin is a prohormone of calcitonin produced in many tissues in response to the high cytokine levels produced during bacterial pneumonia. It is not increased in most viral infections. The usual cutoff is 0.4 to 0.5 micrograms per liter. Below this value, the infection is likely to be viral. Bacterial pneumonia can be associated with much higher values, with median values in the 6 microgram per liter range. CRP is usually normal in viral pneumonias and high in bacterial pneumonia. However, there are many other connective tissue and other diseases associated with high CRP, making this a less useful test. This sketch note summarizes the diagnostic approach to CAP. Physical exam helps to determine the severity of illness, particularly respiratory rate, and not depicted here, blood pressure. The illness severity score, CURB 65, can be used to decide on appropriate triage. Chest x-rays should be performed in all patients with the possible diagnosis of pneumonia. For CAP, there are 3 major x-ray patterns: lobar, bronchopneumonia, and interstitial. Sputum gram stain should be obtained in hospitalized patients and can determine the likely etiology as well as the inflammatory response. Respiratory PCR is now performed in nearly all patients admitted with pneumonia, and it rapidly diagnoses the etiology of CAP. The peripheral white cell count with differential and procalcitonin can help differentiate viral from bacterial pneumonia. Thank you.